Care. Our invited speaker this morning is Dawn Moore, PhD, who's Professor of Medical Education and the Director of the Office of CPD at Vanderbilt University. We're really thrilled to have Dawn with us this morning. Dawn is currently, as I mentioned, the Professor of Medical Education, and he teaches a course entitled Learning Theory and Teaching Applications. He's also serving as the Director for Curriculum Evaluation, as well as his role in the Office of Continuing Professional Development, and he teaches a variety of faculty development workshops. So Dr. Moore received his PhD in education from the University of Illinois at Urbana-Champaign in 1982, and he's published over 40 articles and book chapters and made over 180 presentations at national and international conferences. He's also received the ACCME Raskowski Hero Award in 2009, the Alliance CME Distinguished Service Award in 2010, and the Society for Academic CME Research in CME Award in 2011. He was inducted into the Academy for Excellence in Teaching at Vanderbilt University in 2013, and he continues to work on the outcomes framework that started with his work with Harry Gallus Green and Joe Green and the article in JSEP in 2009, as well as his work on Master Adaptive Workplace Learner. He's going to be talking to us this morning about adaptive expertise, and I'm looking forward to having all of you participate in the conversation. Don, I'm turning it over to you.
Thank you very much, Jan. I guess because we're having a bit of technical difficulties, I'm going to be asking Jim to advance the slides for me this morning. I really do appreciate the opportunity to speak with you today. And before I start, I need to make my disclosure statement. So that's the next slide, Jim. So I do not have any financial relationships to disclose that are related to the content of my presentation. Next. Traditional wisdom suggests that continuing education helps health professionals keep up to date and incorporate the latest research findings into clinical care, resulting in improved patient health. Significant enterprises have been established in each of the health professions to make continuing education available to practitioners. But a large number of patients are not receiving the optimal care that research suggests. You can see on the slide that there's two statements related to the U.S. Institute of Medicine report in 1999 and a European report that was published in 2008. Essentially, it says that healthcare today harms too frequently and routinely fails to deliver the potential benefits that research suggests are available. And doctors, clinicians, pharmacists, and others health professionals are not being adequately prepared to provide the highest quality and safest medical care possible, and there is insufficient assessment of their ongoing proficiency. Next slide, please, Jim. Over the past 25 years, concerns have been expressed about the lack of effectiveness of continuing education in the health professions. For an example, an IOM report published in 2010 entitled Redesigning CE in the Health Professions suggested that continuing education as it is planned and offered today is so flawed that it cannot properly support the continuing development of health professionals. There have been concerns expressed in nursing as well, and a literature review reported in 2006. The following statement was made: continuing education is intended to ensure healthcare practitioners' knowledge is current, but it is difficult to determine if those who attend these courses are implementing what they have learned. To those of us who think there is a connection between continuous learning and high-quality healthcare, these two slides are concerning. Next, Jim. Jim, you're going to have to push the advance button a couple times with this slide, and I'll comment as the slide moves on. Over the last couple years, I've been suggesting in presentations like this one that the issue might be a lack of transfer. Broadly, what I mean that, keep going, Jim. Broadly, what I mean that is that there does not seem to be a consistent transfer of performance data from the clinical setting into CE planning, nor does there seem to be a transfer of learning from the education setting to the clinical work setting. 2 more clicks, Jim. Even though there have been a number of efforts to improve CPD, CME over the last 20 years, it has not changed much, except perhaps for some technological advances, which unfortunately have seemed to continue the prevalent model. Today I'm going to talk about educational planning with a focus on one of the transfer problems, transfer from the educational setting to the clinical work setting. Transfer of performance data from the clinical work setting to the educational planning setting will have to wait for another day. So what is transfer? Next slide, please. So transfer is defined as effectively and continuously applying the specific knowledge, skills, and/or attitudes that were learned in one setting or circumstance to another setting or circumstance, using the principles underlying the specific knowledge, skills, and/or attitudes to apply what was learned in one setting to another setting. So for example, a clinician may attend a CME conference on diabetes because she wants to learn how to manage her patients with type 2 diabetes who are having difficulty with glucose control. The conference provides her opportunities to learn what she needs to do, how she should do it, and under what conditions she should do it. Her goal then is to apply what she has learned in her practice, what I have been calling transfer. Next slide, Jim. To facilitate transfer of learning, a learning activity should include, number 1, learning tasks that must be authentic. Tasks must resemble the tasks that learners will be expected to perform in their work setting. A setting must be created that resembles as closely as possible the work setting in which the new learning is to be applied. Next, practicing authentic learning tasks deliberately in authentic settings and obtaining feedback from a knowledgeable faculty member is absolutely essential for transfer to occur. This is absent from most CME activities these days, and would require rethinking and restructuring the way we currently offer CME activities. And the third element is varying the task and context slightly, because that helps learners become accustomed to using their newly acquired knowledge and skills in novel situations. This may be more important than it seems to us now once we begin to discuss the increasingly complex healthcare environment. So it is important to remember that the combination of these 3 components of a well-designed educational activity creates a cognitive imprint that facilitates retrieval and automaticity in similar clinical workplace settings. Next slide, please, Jim. So right now, I would like you to spend about 60 seconds silently thinking about your most rewarding learning experience. Suggested issues are listed on the slide. It might help for you to jot down a few notes. On my signal, if you are with other people, discuss your thoughts with them. If you are alone, write down how you used what you learned in your work. So starting 60 seconds now. Okay, now for the next 60 seconds or so, if you're with other people, please discuss your thoughts with them if you're alone, write down how you used what you learned in your work. And so 60 seconds starting now.
Don, we're going to try to transfer this over to you.
The
control?
Okay.
Okay.
What do you see?
Should still be.
We're seeing the same thing.
And you would be able to advance it using your keyboard or mouse, supposedly.
So are you seeing the full slide, or are you seeing two?
Yep, full slide. So we're good.
Okay. Well, let me get to where we are. Apologize to the people online.
Are you on? Are you?
Go ahead.
Okay.
So engaging in discussion about and writing your reflections in this way will help you articulate your ideas a little bit more clearly and in a more precise way. So let's get started. When I'm speaking this morning, think about how what I say relates to your most rewarding learning experience and how you might use what I say in your own continuing education programs. So here are a list of what I hope to accomplish this morning. After participating in this session, you should be able to describe and discuss the importance of adaptive expertise in a complex healthcare environment that's subject to rapid and accelerating change. You should be able to describe and discuss a new perspective for transfer that focuses on developing adaptive expertise. And then finally, we're going to spend some time on a strategy for designing learning activities that has some potential for developing adaptive expertise. I plan to address these objectives by talking about responses to these 5 questions. I mentioned in earlier slides that in too many cases, patients are receiving suboptimal care, and continuing education in general does not appear to be helping clinicians provide the optimal care that patients deserve. So I'm going to go at this by responding to these 5 questions. How is our world changing? Are we helping clinicians become adaptive? Is a new perspective necessary? How can we help clinicians become more adaptive and innovative? And are there new metrics for success in health professions education? And by the way, these questions were taken from a 2007 article by John Bransford entitled Preparing People for Rapidly Changing Environments. So how is our world changing? The only constant, as I'm sure all of you know in healthcare, is change. Not so long ago, the pace of change was slower. An innovation in healthcare could be introduced. A person could develop expertise in a certain area and be an expert in that area for the rest of his or her life. Some suggested that it took 17 years for an innovation to be accepted widely in healthcare. So an expert could be, a person could be an expert for a major portion of his or her professional life. Continuing education functions somewhat in the same way and gave a stage to these experts. This is not a criticism on my part, it's just an observation. But then change began to accelerate. Innovation cycles became very short, and information dissemination mechanisms were not sufficiently nimble, evidenced by the 17-year framework I just mentioned. The gap was developing between the innovation cycle and the adoption cycle. Here is what's happening to clinicians and physicians. The rapid pace of change is creating an ever-expanding skills gap between what clinicians need to know at the moment and what they need to know at the next moment. in order to continuously provide optimal care. Look at the diagram in the upper right-hand corner of this slide. You can see that the red arrow suggests that the gap between what clinicians need to know at the moment and what they may need to know at the next moment is ever expanding. What clinicians need to know in this diagram is shown in the table just below the diagram. There's what to do, how to do it, and when to do it. And the chart suggests, or the matrix suggests, that it's not only the clinician that faces this gap, but it's the team and the system as well. So there's a so what is needed to be what clinicians need to know is impacted by a wide range of factors that include not only the clinician and patient, him or herself, and the team and the system. So what is the issue for clinicians? So experienced clinicians who are used to being seen themselves as experts in their profession now must see themselves not only as experts who have developed a strong set of knowledge and skills that are implemented as high-level routine procedures, but now also as adaptive experts who are willing to address the rapidly expanding what needs to be known at the next moment by asking questions, experimenting with new ideas, pursuing untypical sources of information, and learning from their fellow healthcare workers. That includes not only other physicians, but other members of the healthcare team as well, in a context of distributed expertise. So really, what we're trying to emphasize here is that there are two types of expertise. What experts have typically been doing is routine expertise. Routine expertise is concerned with speed and accuracy, certainly valuable attributes in today's fast-paced healthcare system. But another type of expertise is needed for this increasingly complex healthcare system, and that's adaptive expertise. Adaptive expertise involves, first, recognizing that a routine approach will not work in a given problem space, and then reframing the problem in space in a way that allows an expert to explore new concepts and invent new solutions. And let me read that again because I think it's very important for us to get this concept. Adaptive expertise involves recognizing that a routine approach will not work in a given problem space, and reframing that problem and the problem space in a way that allows an expert to explore and learn new concepts and invent new solutions as a result. So this slide represents a concept of the development of expertise that was created by the Dreyfus brothers back in the mid-1980s. Shows that expertise develops in 5 stages. Patricia Benner adapted this model for nursing. I'm sure that most of you have seen and are familiar with this model, but I just want to go through it quickly. So you begin at the novice level, where a beginner has no experience and must depend on rules to guide his or her actions. Next is the advanced beginner, and the advanced beginner has had enough experience to recognize that situations have recurrent, meaningful patterns. Next level is competent, and the individual can rely on long-range goals and plan to determine which aspects of a situation are important and which can be ignored. Typically, at least in medicine, novices are medical students. And medical students begin to become advanced beginners in the 4th year in US-style programs, maybe in the 5th year in European-style programs, and begin to develop competency or begin to become competent, really beginning their residency and postgraduate training. Proficiency then becomes, clinicians become proficient rather as they enter their first 5 years of practice. And that's when they can perceive situation as wholes, as integrated aspects, and consider fewer options in terms of their problem-solving strategies. And finally, an expert is someone who's developed an intuitive grasp of situations and can zero in on routine solutions without considering all the multiple options. So an expert in this model is someone who really works in a combination of intuition and clinical reasoning to address the problems that may be encountered in the clinical setting. But given the changes that are rapidly occurring in healthcare, it becomes clear that two kinds of expertise are needed really now, and that other expertise is what we've called adaptive expertise. And so just to focus on that again, a routine expert has an intuitive grasp of the situation and can zero in on what would be considered to be routine kinds of solutions. But the adaptive expert, and in some cases this person is called master, or in some schemes he or she is called a master, and that's why we begin to start calling this person the master adaptive expert. This person can recognize that a routine solution will not work, and he or she pursues innovative solutions by reflecting on what the issue is and why what he or she knows at that moment may not work. So back to how our world is changing, the first question. Rapid and constant change, then, is transforming healthcare into a collection of complex adaptive systems. And let's see how the clinician fits into that context. Here is the nursing conception of what a complex adaptive system is. This is a good example of how not to design a slide, actually, but I want you to look at just the last property here, which is unpredictability. So as you are thinking about your own clinical experience or your own experience at work, you may think that this particular statement characterizes your own work environment. So in a complex adaptive system, forecasting is inexact because elements change, behavior is emerging, and activities are not linear. The trajectory of this system is unknowable, so you can't predict. You can't, by using what you already know, you can't understand what you need to do for the next level, if you will, of complexity. So going back to our diagram earlier with the other red arrow increasing the size of the gap between what is and what should be, so in that very next moment, a patient with a very different complex adaptive system around him or her may present to a clinician. And this is an example of what I'm talking about. It is a diagram of the complex adaptive system of obesity. Look at the multiple relationships that a defenseless clinician must deal with in this circumstance. But for our purposes now, it's not important to go into the details of this complex adaptive system at this time. Rather, except to say, rather, that this diagram represents the multiple interactions of systems related to the clinician, members of the teams that he or she works with, the setting that he or she works with, the patient, and the community. So let me try to bring this all together. The complex adaptive system is a self-organizing collection of large numbers of components, often called agents, that interact and adapt or learn in order to maintain their existence. How most of them learn reflexively is a matter of great interest and something we don't know a whole lot about at the current time. But what we do know, if a component does not learn, it cannot adapt. If it cannot adapt, its future is uncertain. It also might be that they do not learn correctly and maladaptation results. So there's still much we do not know. But one of the things we do know is that in healthcare, clinicians are one of the many agents that interact and must adapt to the constantly changing system. And what our contention is that to be successful in a complex adaptive system, an agent, that is to say a clinician, must learn and adapt, which is another way of saying that he or she must develop adaptive expertise. Now, I've gone through that over and over again just to make that point that our healthcare system is increasingly complex. In order to function effectively in that healthcare system, a clinician must develop adaptive expertise. But I want to add one more item to this discussion, and that is that critical thinking is an important skill that must be developed to function effectively as an adaptive expert. So what is critical thinking? This is another complicated definition that I'm going to go through slowly, but it's very important. So critical thinking is the intellectually disciplined process of actively and skillfully conceptualizing, applying, analyzing, synthesizing, and/or evaluating information gathered from or generated by observation, experience, reflection, reasoning, or communication as a guide to belief and action. I think the next slide is a little bit easier to grasp. And so this suggests that there are four stages in a critical thinking process. And the definition, and this diagram is built on the definition that I just relayed to you. So the first stage is identifying your own assumptions. So basically, for the adaptive expert, that would be, I think that in this kind of patient, my knowledge in the area of X would work. So you need to analyze those assumptions in the next situation, next stage. And in that case, you would begin to think about whether or not what I already know actually works in this situation. So do my current knowledge and skills equip me to deal with the current situation? And obviously that's a yes or no or even maybe kind of response. If you decide that they do not fit, then you need to pursue some alternative perspectives. How can I reframe the current situation to determine the new knowledge and skills that I need? And then the fourth step is to learn the new knowledge and skills and create new solutions. So that's, if you recall Donald Schoen's work in terms of reflection in action and reflection on action, the critical thinking process is something that really activates that kind of model in which a clinician, when confronted with a situation in which what he or she currently knows doesn't seem to fit the situation, there's a process that he or she could go through to be able to address the new circumstance. And we're suggesting that a combination of critical thinking and adaptive expertise is the best way to handle that. And so to wrap this up again, so adaptive expertise involves recognizing that a routine approach will not work in a given problem space and reframing the problem and its space in a way that allows adaptive expert to explore and learn new concepts and invent new solutions. Critical thinking is crucial to recognizing that a routine approach will not work and being able to reframe the problem and the problem space. So the big question now is, do our current learning experiences cultivate the development of critical thinking and adaptive expertise? So I'm going to ask you to spend about 30 or 45 seconds reflecting again, and I'd like you to recall again your most rewarding continuing education learning that you developed or experienced, developed or participated in rather. And then based on what you just heard from me, I want you to reflect on whether or not this continuing education learning experience helped learners develop critical thinking and adaptive expertise. So 60 seconds to reflect, and again, please do it silently. Okay, now for the next 60 seconds or so, tell your neighbor if the learning activity helped learners develop critical thinking and/or adaptive expertise, or if you're alone, write it down on a piece of paper. And if it didn't, indicate perhaps some of the reasons why you think it didn't. Okay, so keep those ideas in mind as we move forward. My suggestion in terms of why traditional CME activities may not have contributed to the development of critical thinking and adaptive expertise lies in the definition of the conventional view, rather, of what transfer is. So the conventional view is that experts are able to solve problems by applying previously learned skills and knowledge in new settings. So they transfer what they have learned into the new setting, which they recognize from their training. In the new reality, however, many of the circumstances are not recognizable. Remember this slide. At the next moment, a clinician may be confronted with a patient with a set of circumstances he or she does not recognize. And so the ability to transfer what he or she already has learned to this new circumstance is difficult, if not impossible. So back to the question, are we helping clinicians become adaptive critical thinkers? What does it mean again to be adaptive? To be adaptive, clinicians must learn to navigate in situations where they are at the edge of their existing knowledge. Clinicians who function as routine experts rely on what they have learned to solve problems. They become very efficient and proficient at what they do. In many cases, they do not like to vary from this approach. Clinicians who function as adaptive experts learn as they solve problems by recognizing that a routine solution may not work, resisting premature closure, that is, just relying on what they know, and then challenging themselves to search for new insights and perspectives. That second item is probably very important, or actually the first item. Resisting premature closure is an important issue that we really need to remember. So again, this is what happens in conventional transfer. We talked about transfer just a few seconds ago. We mentioned that it was transfer current learning so that it can be applied in practice, and that it represents routine expertise, and that's know what to do, know how to do it, and then know when to do it. So does this current approach to continuing education help clinicians become adaptive and develop critical learning skills? This slide lists 6 characteristics of current CME approaches. So lecture-dominated format, minimal collaboration among health professionals, lack of a timely response to issues that have been identified, an overemphasis on credit, and a focus on course production, revenue generation, and the result of all that is a little evidence of impact or transfer. So we're repeating this statement over and over again, but I think it's important that we realize that the current structure of CME probably inhibits transfer from learning experience to the work environment, even in the area of routine expertise. So here's a sort of a picture of traditional education. Do you recognize this? Maybe it's a hyperbole. And the caption might be, and we will have a test on this on Friday. Any questions? So all that is to say that we really do need a new perspective, and that new perspective is we need to have a new perspective if the routine expertise isn't working during the application process. So we've just suggested that adaptive expertise would be necessary in a situation where routine expertise didn't seem to be working. So to help clinicians develop adaptive expertise, we'll need to help them develop context-specific critical thinking skills in our learning activities and facilitate the transfer of those critical thinking skills into the application process. And as in any transfer process, deliberate practice and feedback by experts is essential. So the point to be made here, this new perspective, is in addition to knowledge, skills, and principles, critical thinking skills must also be transferred. Remember this question? This is the fourth question. So how can we help clinicians become more adaptive and innovative? And in direct contrast to the traditional, the descriptors of the traditional approach that we just saw, we need to be providing learning activities that provide opportunities for learners, for our physician learners, to directly experience momentary discomfort when confronted with a challenge beyond their current knowledge and skill level, to directly experience engaging in processes of inquiry and innovation to address the challenge, recognizing and unlearning previously learned knowledge and skills that are no longer relevant, taking risks where there is ambiguity and uncertainty, and receiving feedback on this work from experts. These 5 principles are very important as you're thinking about designing an educational activity that will equip clinicians to deal with not only what they can recognize in their practice setting, but also those circumstances that are challenging and are not within their fund of knowledge at that point. What I'm going to propose to you is one approach for providing a learning experience that would lead to adaptive expertise. It is based on the work by John Bransford, specifically the STAR Legacy Cycle, also known as the Challenge Cycle, and it was developed here at Vanderbilt and refined at the Life Center at the University of Washington, where Bransford is working now. So what follows is a creative adaptation of a successful application of the STAR Legacy Cycle by Bransford and his team at the University of Washington, working with an aerospace company. I believe that the approach described here can be adapted for continuing education in medicine, nursing, and other health professions. And so we start with needs assessment. As you see up in the upper left-hand corner is a diagram of a gap. And so needs assessment should always be based on the analysis of a professional practice gap. This is what I referred to earlier as the transfer in of performance data into the planning process. So subject matter experts would work on developing content based on the results of the data analysis. Analysis of a practice gap in diabetes, for example, might reveal that clinicians in a given health system were not using shared decision-making in their interaction with patients with diabetes. The subject matter experts would break the content into several modules and create a challenge for each module that reflected the content to be learned in that module. 4 potential modules for a shared decision-making might be: develop a partnership with the patient, determine the patient's preference for information and a role in decision-making. Number 2, ascertain and respond to the patient's ideas, concerns, and expectations. Evaluate the choices based on available evidence. So that's the evidence-based medicine part of the process. Module 3 might help the physician learn how to help the patient reflect on and assess the impact of the options on his or her values and desired quality of living, and his or her capacity to follow through on the options, which sort of relates to patient self-efficacy. And a final module might be to help physicians learn how to make or negotiate a decision in partnership with the patient and resolve any conflict and agree on an action plan and complete arrangements for follow-up. So the learners would work on the challenge through a blend of individual work, group discussion, and sharing, expert comments in many lectures, as well as opportunities for searching for web-based and other resources. Here is how that would work. So let's start with the challenge. These are statements that pose a complex problem to the learner. So there would be a challenge statement for each one of the modules. Effective challenges engage learners in a process of inquiry that requires them to examine current knowledge in the context of a new experience. Think back now on what we talked about in terms of critical thinking and adaptive expertise. This is a key skill for them to develop, and this model of educational design provides them an opportunity from the very beginning to implement or to practice analyzing a situation, determining what they know and do not know, and then determining what they need to do in terms of learning something to deal with the challenge. In some cases, a media presentation of the challenge would be very effective. So then learners are asked to reflect independently and silently on the challenge. This is where they practice the critical learning skills, the critical thinking skills. This is an opportunity for them to explore what they currently know about the challenge or similar situations. Learners are asked to draw on their knowledge and experience to generate ideas about how to address the challenge. And there's always a recommendation to the learner to write down their thoughts so that they'll be able to share their ideas with others in their group. Then learners are asked to share ideas they came up with during their silent reflection with others in their small groups. Groups may be provided with the opportunity to pursue resources external to the group. In other words, they may be able to access the web or use resources that are provided by faculty. A spokesperson is designated to share the group's ideas with other groups, and a whiteboard is very useful in these situations for summarizing the conversation as well as sharing with other groups. In the next phase, the spokesperson from each group shares the ideas that his or her group came up with. Member of the groups then engage with each other for clarification. Challenges may be made to what is presented, and group members must be ready to defend their ideas. This activity encourages cross-fertilization of ideas. The next stage is where experts, and that's in quotes, provide statements that are insights into various dimensions of the challenge and ideas presented by the groups. The comments of the experts might reinforce what was correct coming out of the group conversation, or they may make constructive suggestions about how to improve what is not exactly correct. They even might say, did you think about such and such, that the groups may have omitted in their conversation. This part of the process requires considerable faculty development as does the process itself, because it is not the sage on the stage but the guide on the side. So faculty who have been used to providing long, complicated lectures must be helped to understand that what works in this learning environment is actually mini lectures that focus in on single points and necessarily deal specifically with the problem at hand and not necessarily all the underlying research that goes with it. So learners are instructed to compare their initial thoughts with the comments of the experts in discussion with other groups. They are also encouraged at all times to consult web-based resources and other materials that are provided by faculty. In the next stage, the learners return to their smaller groups for further discussion about what they just heard. The groups are asked to consider would the information just presented by the other groups and or the experts change the group's ideas and or developing approach. Groups may be provided the opportunity to pursue resources outside the group. And what changes in their initial ideas would the group make? And then the groups are asked to be ready to share with the other groups once more. And that's the Go Public stage. In the Go Public stage, each group will present a potential approach to addressing the challenge based on the group's discussion, expert comments, other group presentations, and or information from external resources. A potential consensus approach may emerge or it may not. And after this session, groups may move to another challenge. In our example, they would move from the challenge in Module 1 to the challenge in Module 2 to the challenge in Module 3. Or they may be ready to develop an action plan if they're at the end of the challenges that they need to address. Sometimes it's useful to repeat a cycle for a given module several times, increasing the opportunities for practice and feedback by experts. And this is an excellent point to begin to think about how to assess not only the performance of the group, but what they may be carrying forward in their action plans to implement a change in their practices. So here's some new metrics for success. This is the 5th question of John Bransford's 5 questions. Here are a couple of metrics to be considered. You might think of some of your own. So did learners achieve desired outcomes? That is beyond satisfaction in self-reported learning scores. Obviously, this would require your taking some measurements after the educational activity, maybe 3 to 6 months out. Were teaching strategies assessed to determine if the learners would provide opportunities for practice and feedback? And finally, did the program provide the resources for the teachers to develop opportunities for inquiry and innovation that are characteristic of an adaptive expert using critical thinking? So there's a little bit of a different assessment approach than what we've been used to in continuing education. We're looking more at downstream outcomes by the learners and whether or not the teachers, the faculty, and the program were set up in such a way to help the learners achieve their objectives. So what are the take-home points? Number 1, the healthcare environment is increasingly complex. Number 2, to increase the possibilities that clinicians can provide the best possible care to their patients in this environment, they need to develop, the clinicians that is, need to develop critical thinking skills. CME activities should be designed to transfer clinical and critical thinking skills, and an inquiry-based approach has promise for developing and transferring clinical and critical thinking skills. This is a diagram that some of you may recognize, and I've highlighted the patient health status and community health phases of stages of the outcomes framework to point out that this kind of approach is going to begin to move CME in terms of addressing the patient health status and community health status issues that we all want to address It's not going to happen overnight, obviously. There are lots of variables involved. But I think by developing a inquiry-based approach that begins to look at all those variables, we'll begin to address some of the issues that are preventing CME from reaching its desired outcomes. So that's all I have to say today. I think I'm right up against the time that we had set aside. I think that the best way to answer questions is for you to write your questions to me at the email address that's on this slide, and I'd be happy to address them over the next day or two. Really appreciate your willingness to participate in this webinar and your attention, and I look forward to hearing your comments and whatever questions you might have. Thank you very much.
Don, thank you very much. This was a very interesting presentation, and we've had some very positive comments on in the question section about really some of the audience has really encouraged and believe that it's a leap forward, and that they're really going to try to reflect on how this relates to their role as medical education. As I was sitting here thinking this morning and listening to your presentation, one of the things that popped in my mind was all of this discussion about Ebola and the current practices that they've got for protection of healthcare professionals, and that whole thing is having to be revamped, really applies very nicely to thinking about critical thinking skills, and that the routine skills didn't really work as well in some ways as they should have. So do you have any comments or thoughts about that?
No, I think you're exactly right. I think the issue is obviously Ebola is such a different kind of infectious disease that most clinicians have not had the opportunity to experience as a clinician. That it really requires that sort of reflection and critical thinking, and then developing that adaptive approach to managing not only those patients, but the safety of the clinician and the people who are in his or her team.
Okay, great. I don't see any other questions currently, so thank you very much, Don. We really appreciate your time and effort this morning, and we look forward to hearing more from you in the future.
Thank you very much.